All righty, folks. Good morning. Oh, there we are. I'm sorry. Good morning. This is Dr. Mike, and welcome to the 12 Days of Medical Exercise Training. This is day number 6, and today we're going to talk about the Medical Exercise Training Assessment. So we've done 5 days up to this point. We've got a slide presentation for you that we're going to go through in a few moments. So today's segment, I promise, is not going to be as long as the other segments because I know I'm trying to make sure we give you all the information you need. And let me just simply summarize again why we're doing this. As you guys know, I'm the actual founder, the guy who developed the whole concept of the medical exercise specialist certification and workshop. We started back in the 1990s with this. One of the key things I'm seeing now is we're going to see an increase in the number of medical exercise professionals out there. And this just can't be as simple as, hey, I took a couple of courses, I know a couple of things about breast cancer recovery or something about backs, and now I'm going to go out here and start doing medical exercise services. Folks, it's not going to work that way. This has to be more comprehensive, more detailed, more professional. It's not just simply an extra component you add to your personal training toolbox. This now becomes really more of a true profession. Because now what you're going to do, you're going to sit down with doctors, therapists, chiropractors, and you're going to sit down with these folks day in and day out, working with clients, working side by side with them, and you're going to be asked to communicate and also document and communicate in a written as well as a verbal form. So it now takes on a completely different complexity. Along with that, let me ask you, how many hospitals, physical therapy clinics, or chiropractic clinics have you seen close in the last couple of years? If anything, you're seeing an expansion, which means this profession is here to stay. And when you think about it, we estimate 80% of the clients that are leaving a physical therapy or chiropractic facility need MET services. 80%. That means there's going to be a steady supply of clients for you, the medical exercise professional out there. So this is just going to get bigger and bigger and bigger. So this 12 days of medical exercise training is designed to give you some of the key components you need to go out there and really manage your practice well, understand where you fit into the medical exercise training continuum, but more importantly, just to make sure you understand all the ins and outs and do's and don'ts of what you're doing. So that's what we're going to do. So we're day number 6. We got a slide presentation here for you. Let me open up the slide presentation here. If you have had some problems with accessing our webinars, the live webinars, they are out on our website at if you go over to postrehab.com and just simply hit the tab for I'm sorry here, folks. We're just making sure that our links are all connected here and working for us. If you go over to postrehab.com, click the link across the top of the page. You'll see a link there at the very far right that says MET blog. Click that link, and all of the recordings are there. So if you're out there watching this one now, you haven't seen the previous recordings, they're out there and they're available for you. Okay. So let's see here. Make sure we get all of our stuff going here. We've had a tremendous number of individuals that have are participating in our webinars. We got a lot of people that are watching the webinar replays. So this is just going to get bigger and bigger. And yep, there's our webinar going on right now. I'm actually watching myself live, which is a little weird. So let's go ahead and let's now move on to our slide presentation. Just want to make sure that was up and working for us. Now we're going to kind of go through a little bit of a tunnel here, folks. So forgive me. It's going to get a little bit confusing here. Hold on one second. We're going to go to entire screen here. And I'm going to share my screen. There we go. And you should now see my PowerPoint presentation. And now it's going to go full screen. All righty, there we go. Alrighty, folks, good morning and welcome to the 12 days of medical exercise training. My name is Dr. Michael Jones. Just call me Dr. Mike. And this is day 6. Day 6 of 12 days of medical exercise training. We put this together, as I said before, to give you the skills, knowledge, and understanding as to how to go out there and build your medical exercise training practice. So that's what this is all about, just helping you build your practice and get out there and start doing the things you need to build a strong and successful practice, connect with medical professionals, and most importantly, really produce the outcomes for your clients, because that's what's going to improve your profitability and your credibility along the way. So we're going to go ahead and get started with our slide presentation. Again, day 6, 12 days of medical exercise training. We're talking about MET assessments today. Again, our segments, our webinars and segments are all sponsored by the MedX Pro Network. You can go over to medxpronetwork.com to get more information. If you've listened to our previous webinars, you know that the MedX Pro Network was put together as a means of helping medical exercise professionals build their practices, connect with medical professionals, produce better outcomes, and more importantly, make your practices more profitable. Our big push this year is to actually make medical exercise training a provider offered benefit for health insurances. And we're out there, we're meeting with health insurance companies all over the country right now trying to do that. And that's what our big push is to make sure that our medical exercise specialists can actually receive reimbursement for medical exercise training services. So to get more information, go over to medxpronetwork.com. You'll get everything you need there to find out about the organization and to find out about the benefits it has for you. Again, here's our universal medical exercise training logo. If you're a medical exercise specialist certified through our organization, please communicate with us. We'll give you a copy of this logo. It has medical exercise specialists around the edges instead of medical exercise training. We want you to go out there and use that logo and use it proudly, because we put this logo together because we wanted to show the distinct differences between the medical exercise specialist and the personal trainer. Not saying personal training is bad or anything, but obviously if you've gone through our course, you've done a lot of additional work, and that additional work now has allowed you to go out there and utilize the title, but more importantly, connect with medical professionals and manage the medically based clients. So please contact us. Email me at drmike@postrehab.com to get a copy of the logo. Our 12 days of medical exercise training, we're on day number 6, so we're going to talk about MET assessments. Previous to this, on day 1, we talked about the medical exercise training practice business model. Day 2, we talked about the scope of practice and the role of the medical exercise specialist. Day 3, we spoke about medical exercise training systems, the systems you need to put in place in your practice to make it grow. Day 4, we talked about MET marketing to the general public. Yesterday, we talked about the client management system. We went over that in detail, the 9 steps of the client management system. And today we're going to talk about MET assessments. And you can see day 7 tomorrow all the way to day 12, we got some rather interesting topics to talk about. And again, webinar series is free. So let's talk about assessment. So let's talk about the foundation of assessment, okay? The basic foundations of the assessment. Number 1, the most important thing with the assessment from a medical exercise training standpoint is you got to get a good history, but don't chase symptoms. You ever sit down with a client and they have knee pain or back pain and they're telling you everything under the sun about their pain? In our medical exercise specialist training series, we go into depth with regard to assessment procedures and assessment techniques. And one of the things that I mentioned is when I was a kid, there was a TV show on called Dragnet. Now, some of you may remember it. Hopefully, some of you are as old as I am and you remember Dragnet. But you remember, I think it was Sergeant Friday would always say, the facts and only the facts. When you start working with medically based clients, one of the things that they'll do is they want to tell you about their pain and how much it hurts and this and that and the other. And you got to kind of stay away from just simply chasing their symptoms and really get an idea of saying, you know, Mr. Smith, when did you see the doctor? What procedures were done? What makes you better? What makes you worse? Those types of things. Second component of the assessment process, and these are the foundations of the assessment process, include a musculoskeletal screening, looking for red flags. And red flags tell us that the client is appropriate for exercise. Now, we go over these red flags in great detail in our medical exercise specialist training series. One of the things we did when we started this concept some 21 years ago, actually 22 years ago now, was we wanted to make sure that the medical exercise professional could identify the inappropriate client. And you will get some clients out there that are not appropriate for medical exercise services. And you need to be able to identify those. And the easiest way to identify those is what we call red flags. So along with that, then we get into the assessment process itself. What are the key components of the assessment? This is item number 3. The MET assessment is designed to help you establish baselines in range of motion flexibility for your client, strength, balance and coordination, joint stability, cardiovascular capacity and endurance, and functional activities. The assessment is to get an idea of what's going on with the client and establish baselines. These baselines will be the items or the data that you will use to make determinations of goals, both short-term and long-term, and then also these goals will now allow you to develop the program to reach these goals, and every 30 days you come back and you readdress the goals. Number 4 in the foundations would be the functional assessment scale. Functional assessment scales, we actually put a bunch of these together about 8 or 9 years ago. They do not belong to us. We are not the authors of the functional assessment scales, but these are things that are used on an ongoing basis and regularly in rehab settings. Nursing homes, rehab facilities, both long-term and short-term, physical therapy, chiropractic clinics, and these scales are used by insurance carriers as a means of documenting client progress. And then the last component with the assessment process is the ability to determine and establish program goals. First set of goals are short-term, and then those are 30-day goals, and then we have long-term goals that are 60 to 90 days. So in our presentation this morning, we're going to go into more detail with each one of these. So the principles of assessment. Now, we talked about the foundations, the basic foundations, but here's some of the principles. Number 1, great clinicians do the basics exceptionally well. Now, folks, when I came out of PT school, I wanted to know every possible assessment procedure. So I went out and started taking orthopedic courses. I took neurology courses. I took advanced courses in manual medicine, joint manipulation. I even got a master's degree in osteopathic medicine at Michigan State, where I learned how to do osteopathic manipulation under some of the giants such as Phil Greenman, Carl Steele, Barbara Briner. Some of these people, I read their books in undergraduate school and PT school. Now I'm in classes with them or in the clinic with them. But one of the things that they said, Dr. Greenman said, was the great clinicians do the basics exceptionally well, which made me kind of change my thought process. I was out there trying to learn every assessment procedure, but I realized the key to the assessment process was really understanding the basics of what I was doing and being able to do those basic assessment procedures so well that I could get all the information I wanted out of those or needed out of those, and then add more advanced assessment techniques to confirm what I knew. I meet a lot of our MES students out there, and they want to know the advanced assessment techniques, but you need to know the basic ones, because the advanced ones are based on the basic ones, or the advanced ones are based on the idea you did the basic first, you figured out what the implications of that were, and then you moved on to the advanced technique. So please understand, the great clinicians do the basics exceptionally well. And here are the principles of the assessment. You have to have a great understanding of anatomy and pathology, because the assessment procedures is designed to provoke a response. We provoke a response by provoking the anatomy in the area or in the region that we're testing, or provoking the pathology. The pathology normally is going to have some type of pain response. So we've got to understand the anatomy and pathology very well, so we understand what our assessment procedure is doing, both anatomically, biomechanically, and even from a pathology standpoint. Then the second thing is you got to get a good history. Again, don't chase symptoms, and you also have to think and assess the client's function. Now, for you guys, for medical exercise professionals, your role in the healthcare continuum is to manage the residual functional deficits that are left over after physical therapy and chiropractic care. That's what your job is. The physical therapist's job is to manage the dysfunctions associated with diseases and organ processes. The physician's job is to identify and diagnose the disease process, establish a treatment plan where he or she will now refer the client to chiropractic or physical therapy or occupational therapy. The therapist or occupational therapist will then, or physical therapist will then manage the dysfunction associated with the disease process or the organ dysfunction. And then you, once the physical therapy and chiropractic or occupational therapy is over, your job now is to manage that residual functional deficit. So what you have to do is continually think and assess for functions. Now, when you look at the assessment process, you have to select the appropriate assessment activities. And the biggest one, number 5 here, I find is listen. Your client will tell you what is wrong and what needs attention if you listen to them closely. Let me give you a good component or a good idea you need to continue on with. If you can, ask your clients to show you how they injured themselves, particularly with individuals with hip or knee disorders or lumbar disorders. And when they demonstrate to you how they injure themselves, and do this in a very low intensity environment, so they don't do the same thing and re-injure themselves. But what I found over the years is when clients show me what they did, I can now look at them, and based on the anatomy and pathology of conditions of that region and the biomechanics that they are showing me, I can now determine if it's an ACL tear, if it's in the knee, or a meniscal tear, or if it's a disc herniation or a facet joint in the spine. I take that information and combine it with my assessment procedures, and guess what? Now I know what's going on. So listening to the client, letting them explain to you what's going on, and then once you've got a pretty good explanation, you may ask them, hey, Mr. Smith, can you show me what you did, or show me what actually causes you pain without exacerbating your condition? So again, understand the related anatomy and pathology of the client's condition. Get a good history. Don't chase their symptoms, particularly don't chase pain. 3, think and assess for function. 4, make sure you select the appropriate assessment activities or procedures. And 5, listen. They will tell you what's wrong with them if you listen, but you've got to have a great understanding of anatomy and pathology to understand that. So let's go through these quickly, these key points here. Okay, so let's go back here in our outline a little bit. We looked at the foundations of the assessment. What I'm going to do now is go through these components here and talk about each one a little bit. Okay. Okay. So, number 1, the medical history. With the medical history, you're going to ask the client to complete the written medical history form. So they may be sitting out in the waiting room and they fill out the form. But what you're going to do when the client comes back to you, you're going to take that form and you're going to conduct a history interview with them using that form. So you're going to go through every item on the form, go right through it with them. Now, you're going to verify any notations that are on the form. Okay, so any notations the client has made on the form, you need to make sure to address those, but still ask the client each and every question. What I mean by that is, Mr. Smith, have you ever had surgery? No. No means, yeah, I did, but I don't want to tell you because I don't want you to tell me I can't exercise. And it was a minor surgery. It was a lobotomy. I don't have headaches or anything like that anymore. It's not a big deal. So give you an example. For some of you out there who've taken our MES course, you know I've had hip surgery. I had hip surgery. I was an Army paratrooper for years. Had a dislocated hip. They could have put a couple of pins into my hip. I haven't had any problems since then. I went back on jump status, jumped into a number of different places over the remaining period of my career. And this happened when I was about 18, 19 years old. Never had a problem. But let's say I have a job interview, okay, and on the job, on the application, it says, have you ever had surgery? Folks, I can tell you pretty much every job I ever interviewed for after I got out of the service, I said no, because the surgery wasn't a big issue. And it's not. It doesn't limit my function. But let's say the client is coming in to see you. Would you want to know about that old surgery that was 20 years ago? Yes, you would. So please, if you would remember, the client is looking at this from the standpoint of, if it doesn't bother me, it's not a big deal. That's why you need to sit down and conduct the medical history interview. And any notifications or any notations that are on that form, you need to address them. And you're going to use this to determine if the client is appropriate for exercise. You may find the client was injured 2 days ago. With that injury, that's causing them so much problem that now we need to look at other things with the client. So they may not be appropriate once we get into getting a good medical history. So number 1, medical history. Number 2, the musculoskeletal screening. This is to assess musculoskeletal integrity, again, to determine if the client is appropriate. The screening itself should require no more than 20 minutes. Now, you have to screen them to make sure they're appropriate. Here's the reason. Just because Dr. Smith referred the client over to you doesn't mean they're appropriate for exercise. And I've had several patients over the years that were referred for physical therapy. They weren't ready. They needed further medical or surgical intervention. The same thing will happen with you. Let's look at the environment you're in. Insurance carriers are cutting back on physical therapy. A client's sister heard about you through their loved one. They now bypass physical therapy because they don't want to pay the deductible. They don't have a health insurance, so they come to you after they've had surgery. So they're coming to you for the exercise program because they think physical therapy is just exercise. You know, they aren't going to get any of the acute care management techniques. So they come directly to you, and they come in with a significant swelling in the knee, limited range of motion. Is that your client? No, you need to refer them back. So you still have to screen these clients to make sure they're appropriate. And I will say this, if you refer that client to a doctor, therapist, or chiropractor, you may actually find that ends up being a good potential referral source for you because you made the professional judgment call. This isn't a good client for me. I need to send them back. So the screening itself is a short screening. It's not an assessment. Notice the difference. An assessment is the full-blown everything. The screening is just a component of the assessment to see if the client is appropriate. It should take no more than 20 minutes. It's not a diagnostic tool. We're not going to give the client a diagnosis, and it should be preceded by the medical history interview. Please make a note. Never touch a client until you do some type of medical history first. And the screening is to determine if the client is appropriate for exercise or has potential red flags for exercise. That's number 2, the screening. Number 3, now we get into the MET assessment. So now prior to the assessment, we've done a medical history, done just a quick check to see if the client is appropriate for exercise. And the quick check really has 2 components. Part of it is in the history. The second part is in the screening. Once we've determined from the screening and the history they're appropriate, now let's get into the MET assessment. First thing we're going to do is look at posture and identify muscular imbalances. We're also going to look at range of motion. Now, remember, folks, for the most part, most of you have done range of motion by just kind of eyeballing. We're finding more and more insurance carriers are starting to pay for MET services, which means it's only a matter of time before insurance carriers will say, hey, we're not going to pay your claim. They paid them in the past for you. We're not going to pay the claim because now we need more specifics with the assessment. So range of motion, they may want goniometry testing. Flexibility, they may want specific testing procedures such as the Thomas test. If you have clients that have balance issues, they may want you to do something like a Tonetti or Berg scale to actually give a specific on how good or how bad the client's balance is. So they want actual documentable objective numbers. 5, coordination. We recommend utilizing certain PNF activities to determine the client's coordination level and then grade it based on that. Number 6, joint stability. We have a spinal stability test that we actually teach in the MEST program. And with this spinal stability test, we find it's pretty accurate with regard to the client's stability level. And as the client progresses through the exercise programs, that stability testing actually should show improvement. Number 7, cardiovascular and or endurance testing. Some type of step test or something along those lines. I know one of our medical exercise program directors, Rich Gafter, I think Rich may be on the webinar. Rich developed or utilizes, I should say, a get up and go test to determine clients' cardiovascular capabilities and endurance. So you need to come up with something that is measurable. And then number 8, functional activities. I give you an example here, the Listholm scale. This is a scale that's used, it's one of our functional assessment scales. This is a scale that's actually used for clients that have knee disorders. Regardless of the disorder they have in the knee, this scale now allows us to look at the client, have them perform a number of functional activities, and then based on those functional activities, we grade each one with a point value, add up those points, and now gives us a point value for the client's functional capability. These functional assessment scales, we have a number of them for different regions of the body. So when we look at this idea of the MET assessment, the assessment includes these items: postural and muscular imbalance review, range of motion, flexibility. And when I say range of motion, we may need goniometric testing. That means you need to go out and take appropriate courses, not just look up on the internet, read a book and do it, but get someone to train you who's done this over and over again in a clinical setting and they're licensed to do it. Not just someone that says, hey, I kind of know how to do it, I'll show you. No, you need to get specific training on it so you report numbers appropriately. Think about this. You report a number on a client that says their range of motion is only 30% based on the number you give. Maybe that client has a disability rating that's coming down the road, or they've got a lawsuit. And somehow or another, the lawyer or the opposing counsel gets, their lawyer or opposing counsel gets a copy of your assessment procedure where you've inaccurately reported the range of motion. And now this client goes to court with this information, and the information is skewed. And as a result of that, they get a lesser or a greater settlement. So you have to make sure that you get the appropriate training in these things. So range of motion, you may need to get goniometric training. Flexibility testing, you need to do that. And sometimes with flexibility testing, it's not just simply goniometric testing, but it's also looking at muscular imbalances. I give an example here of the Thomas test. It allows us to look at a number of muscular imbalances in the anterior aspect of the pelvis and the thigh. Balance testing, you may need to use something along the Tonetti gait and balance scale or the Berg scale. Number 5, coordination and balance. We use PNF activities. Over the years, we've used PNF activities with a number of our neurologic and senior clients, joint stability testing, and then a step test or some type of test for cardiovascular capability. And then again, and I'm repeating myself, but I want to make sure we get this clear. With functional activities, you have to look at something like along the lines of a functional assessment scale. So this now explains the MET component. These are all the things that you may have to address in your assessment. It just depends. Okay, it depends. Now, in our MEST program, we go over these and more, but also when you join our MedX Pro network, we actually give you assessment forms that actually list the procedures that need to be done based on a region of the body, so nothing falls through the cracks. You always know exactly what procedures need to be done. It allows you to actually note your findings in a very succinct, very professional format, so now you can share this with doctors, therapists, chiropractors, your colleagues, or maybe an insurance carrier. So that's number 3, the MET assessment. Number 4, measuring function. Now, we just talked about this at the end of our slide here with number 8, functional activities. We can talk about it a little bit more here. Measuring function. Function is a big thing. Everybody talks about function. And when I came out of PT school back in the mid-80s, function was the big buzzword. And the reason? Medicare established new reimbursement guidelines. And what Medicare said was, hey, if you're going to see our patients, you need to frame your physical therapy services based on the idea of the client's functional deficits and then measurable functional goals that we can now look at 30-day, 60-day, and 90-day intervals to determine if the client is making progress. And those goals must be functional and they must be related to the assessment process where you identify deficits in the client's functional capabilities. And what we're trying to do is maximize the client's functional levels. So along the way, we found in our clinics, we found these functional assessment scales. First functional assessment scale here is the cervical oswestry scale developed by a guy named Gordon Waddell. And it's a scale, it's more of a subjective scale to some degree, but it's one that's consistently used for individuals that have cervical disorders. Also some head and cranial disorders. Second one here, the functional scale for ankle assessment. This is one used for clients that have ankle disorders, Achilles tendon ruptures, ankle fractures, ankle sprains. Number 3, the functional status index. This index actually is developed primarily for individuals that are significantly infirmed, such as the older, more frail client that has more systemic disease, Parkinson's, generalized arthritis, maybe individuals that have undergone transplants. And as I said before, some of our neurologic clients, including Parkinson's, MS, strokes, we use this functional status index, and definitely we use it for our seniors because it allows us to note their ability to perform functional activities. We go over these in our MEST program. The Harris Hip Function Scale, a scale designed primarily for hip replacement clients, but it works well for clients with any type of hip disorder. The List-Holmes scale, and this is probably one of the best functional scales we've ever seen. The List-Holmes knee scale actually works for any condition in the knee, total knee replacement, meniscal tear with arthroscopy, patella tendon rupture, ACL reconstruction. It works across the board, whether they're athletic or non-athletic. Next item here is the Oswestry scale for the lumbar region. When Dr. Waddell put these scales together, he also had a lumbar scale. Okay, and with these scales, they actually use point values too. The functional shoulder strength scale, obviously for any type of shoulder disorders. And then the last one we have here is the Tonetti Gait and Balance scale for any client that has any type of balance disorder or gait disorder. And remember, they're two separate things. Client can have a balance disorder just simply sitting. The client can also have a gait disorder. So they may have a gait disorder without a balance or sitting or standing disorder, or you have a client that has great gait capabilities, but they just simply have a balance problem, like initially when they stand, but once they get moving, they're fine. So the Tonetti Gait and Balance scale breaks the two components into separate entities and then grades each one. Now, the great thing about these scales, they all use a number of activities in their testing process, and with each activity, the client gets a point value. And there's a scale that goes along with each one. So let's say with the List-Holmes scale, we ask the client to climb the stairs. They go up the stairs, and then we actually are given a scale to grade their capability going up and down the stairs. We now take that point value, add it into the point values for other activities we ask the client to do, and we come up with an overall point value for their functional capacity. That now allows us to say this client's functional capability is 14 on our assessment today. Then 30 days later, we come back and we reassess them, and now the client's point value is 20. So that means they made a 6-point improvement. That now allows us to easily and very simply show improvement, and that now verifies the effectiveness of our program. So with these functional assessment scales, it's a snapshot of functional capacity for the client. It determines program effectiveness. If the numbers are going north the way they should, then our program is effective. It's a battery of activities and questions to determine the client's functional capacity. The scales are scored and then reviewed, and we should reassess the client utilizing the scale roughly once every 30 days, and then provide a report to their doctor, therapist, or chiropractor. So now what we're doing here is we're now partnering with the medical community to say, hey, I'll do the exercise component because the client has residual functional deficits. I'll verify how effective my program is by utilizing one of these functional assessment scales. And doc, you don't necessarily have to understand the scale. All you've got to do is understand basic arithmetic. We do the scale based on the region of the body that is affected by the client's condition. We send you a copy of the scale within the first week after we see the client initially. Then every 30 days, we send you an update on the scale along with our progress report. And what we should see is this client's functional capabilities are improving. We're finding that insurance carriers like these scales also because it makes it real easy to determine if the program is appropriate and effective and acceptable, or if the program should be discontinued. So these functional scales, they work, and they work exceptionally well. That takes us now to number 5, program goals. Use critical job demands, and CJD means critical job demands. You'll see that later on in our presentation if we haven't looked at it already. But when you develop program goals for your clients, you look at their residual functional deficits, and then you look at these deficits and say, well, what are your critical job demands? Now, critical job demands means demands in their home environment, what activities, what tasks they have to perform in their home environment. It also means in their work environment, what activities and tasks must you perform in your work environment. And then lastly, their sports or recreational environment. Now, any of these 3 and all 3 can be affected by their functional deficits, or none of them can. It just kind of depends, but you want to use something that says the client has to do this in their normal activities, and we're going to base our goal on them being able to do that because they have a residual functional deficit we need to address. And because of this deficit, we need to have a measurable means of determining if the exercise program is effective and at what point the actual exercise program needs to be discontinued because we've reached the highest level on the scale, or we've maxed out the client, one or the other. So the goals should be measurable and functional. And our 30-day goals lead to our 60 and 90-day goals. So here's an example. We had a 72-year-old female who underwent a total hip replacement, THR. She has birds. And I know you probably read that. It's like, what does it mean that she has birds? Well, this young lady, and I'll say she's a young lady at 72 because I remember this client. She was pretty spry and chipper. She just had an arthritic hip. She had it replaced, and she lived about less than a quarter mile from a local grocery / pet store. She lived kind of in a rural suburban area, and she had these birds, and she wanted to be able to walk to the store, get her bird seed, and walk back. Okay, she had like 3 or 4 birds. The bird seed came in 10-pound packages. So she goes through physical therapy in the hospital. She gets home therapy, then she goes to outpatient therapy, and when she's done with outpatient therapy and she's discharged, a couple of days later she walks to the store. She gets to the store, but on the way back, her hip starts to hurt. And she notices going to the store, the hip doesn't bother her, but coming back carrying the 10-pound bag of bird seed, the hip started bothering her. So our goals, our short-term 30-day goals was the client would be able to walk 100 yards or stand for 30 minutes without pain, no hip pain. Our long-term or 60, 90-day goal was the client would be able to walk 300 yards and carry a 10-pound bag of whatever. 10 pounds didn't make it if it was bird seed or sugar, a 10-pound bag. That was it. That now was our long-term goal. Once the client reached that long-term goal, 90 days later, the client, from our standpoint, had now returned to their previous level of function, and we can now step the client down from medical exercise training now back into personal training. So this idea of measurable goals works and works really well. Now, for this client, we were able to establish a clear-cut, easy goal. We didn't have to use the Harris hip scale with this young lady, even though we did perform a Harris hip scale on her. We found with this one, this was clear cut and easy. She had clear goals. She wanted to be able to walk so far and come back. She was independent with everything else. That's what our program focused on. So there we go. We have clear functional goals. Her critical job demand was walking to the bead store and then coming back. There we go. Now, if you're going to do assessments, you got to do documentation. That's why I said earlier, we're not going to get into the assessment procedures, but get into all the parameters around the assessment. So once you do an assessment, you need to develop a one-page assessment summary and forward that to the referral source, the medical professional that referred the client to you. You need to forward them a copy of your one-page summary within 72 hours of you seeing that client. Use a form, or some type of assessment form, or a narrative for your reporting. Should be no more than one page. Note the goals of the program, note any precautions that you are going to use in the program, and the activities you're going to use in the client's program. And then once you forward that on, then every 30 days, you're going to follow up with a progress report to that medical professional who referred the client to you. And in that progress report, you're going to address the goals that you noted when you did the assessment summary. So now you see how it all kind of comes together. It's all going full circle now. Client comes in, we do our medical history, we do our screening. Client is appropriate, we now complete the assessment. This all can be done within an hour. Then once we've done the assessment, we establish a program based on short-term and long-term goals, which are based on the client's residual functional deficits and their critical job demands. We then write up a report, send that to their doctor, and then we get the client started with the exercise program. Our goals should be measurable, and our goals should actually stair-step or cascade on each other. Every 30 days, we do a follow-up progress report addressing the goals. And at that time, we can also use one of our functional assessment scales that we talked about here. Okay. Here are our functional assessment scales. We can revisit or perform one of these every 30 days to give us an idea of the client's functional improvement. Or in this scenario, we had a client that had pretty clear-cut goals. We didn't necessarily need to use a Harris hip scale for this. So you can see now how all of this now starts to tie together. It all becomes one continuous loop. And this is why we say now you've got to look at this idea of having goals in place, systems in place in your practice, and now making sure that you are continually keeping up to date with all of this stuff. It's easy to have some things or concepts fall through the cracks. And folks, this is what medical professionals are expecting from you. So when I said earlier at the top of the broadcast that we talked about the idea of we now need to move this to a more professional footing. You're moving out of the personal training realm where the only person that you were beholden to was the client. As long as you entertained them and they had some improvements, and to some degree you were their psychologist, great. Now you're getting a referral from a doctor, therapist, or chiropractor. A little bit higher level of professionalism, client management, documentation, and accountability at this point. So now you have to start putting these systems in place. You have to be aware of all these things because the doctors are expecting this. That's why we're going into these 12 days of medical exercise training. Because you see now we got to kind of up our game, up our level, our standard of professionalism, and do a little bit more and a little bit better. Now, of course, hopefully, as a medical exercise specialist, you're going to get paid a little bit more. So you're getting compensated more, but you're being compensated for a higher level of professionalism. Our ultimate goal here is to bridge the gap between healthcare and fitness. And as I said before, we're going to show this picture in each one of our webinars. At the conclusion, we've got a medical professional here with the chart and the dumbbell. In this scenario, we realize that we've got to work together to bring about an improvement in health across the board for our clients. Exercise is a key in long-term management of most medical conditions. We've got to have the medical professionals there to give us the diagnosis, to help us from the standpoint of medical diagnostics, the medical treatments. Exercise and the medical management process should go hand in hand. And I hope at some point within the next 10 years, we're going to see more of our medical exercise specialists working in hospital settings where they're not working under the physical therapist or under the physician, but they're working as an equal professional in conjunction with these others, all working on the same team, because exercise certainly is going to become more and more important, especially as we're adding more individuals to our healthcare roles. So we do have our medical exercise specialist course. So if some of these things we've talked about with regard to the assessment process or the assessment procedures are interesting to you, then you may want to join our medical exercise specialist training series. We have an online component, a study group component, as well as an on-site component. This is the real medical exercise specialist. We actually started this back in 1994. You've probably seen recently there are a couple of groups out there that want to kind of hop on our name and hop on the success our MESs out there have been able to sustain. But this is the real one. We started this in 1994. So if you're interested, please, if you would, go to medicalexercisespecialist.com. When you go over there, you'll be able to see our on-site workshops. We have them in Houston, New York, Toronto, Victoria, BC, and Washington, D.C. this year. We have 2 courses in each location. And when you go to medicalexercisespecialist.com, you'll be able to get information on our internet-based training, our study group training, as well as our on-site courses. We have a study group that's starting on January 19th, a couple of weeks from now. We meet alternating Tuesday evenings at 9 p.m. Eastern, 6 p.m. Pacific, and we go through the medical exercise specialist program. We use live sessions. We use Google Hangouts just like this one, and yours truly is the instructor. If you want to get more information on our MES study group, it gives you kind of the best of both worlds. A live session without having to travel. You can do this in the comfort of your home, and if you can't make a session on a Tuesday night, they're recorded. So go over to medicalexercisespecialiststudygroup.com to get more information on that. And with that, we're going to conclude. So this was day 6. Tomorrow we're going to meet same time, same place again and talk about medical exercise training, documentation, and communication. So we appreciate you taking the time to spend with us. If you want to look at other recordings from our 12 days, go over to 12daysofmedicalexercisetraining.com. You can register there, or you can go over to our blog. Just go over to postrehab.com. On the upper right-hand corner, you'll see a link that says MET blog. Just click there, and all the recordings are actually on our blog. So thanks again for listening in. We wish you all the best in building your medical exercise training practice. We'll be back again tomorrow for our next version of the 12 days of medical exercise training. So look forward to having you. So this is Dr. Mike. Thank you again for joining us. Join us tomorrow. And if I can be of any assistance to you, email me at drmike@postrehab.com or give our office a call at 888-610-0923, or you can just go to our website at postrehab.com. So thanks again, folks. Best wishes to you. Have a great remainder of the weekend, and we'll see you tomorrow. Same time, same place. Bye-bye. And tomorrow, we're going to talk about documentation and communication for medical exercise training. Thanks again. Bye-bye.